What if I told you that right now, while you're watching this, your blood type is quietly deciding how you might die? Not someday, not in some abstract future, right now. And here's what makes it worse. You could run a 10K, feel completely fine, have zero symptoms, and still have a 90% blockage silently growing inside your heart. Because your body is that good at hiding it from you. Every protocol on this channel is reviewed by a clinical pharmacist and researcher. You probably think your blood type is just a letter on your driver's license. Maybe it matters during surgery. Maybe it makes you a universal donor. That's about it, right? That single letter is actively shaping how your blood clots, how your arteries inflame, and how likely you are to survive the next decade. And almost no doctor is telling you this in the office. If you've crossed 40 and you think you're fine because you feel fine, this video was made for you. Stay with me. Block 2. The silent engine. Let me ask you something personal. When was the last time you actually thought about your heart? Not in a metaphorical way, not love, not courage. The actual muscle sitting behind your sternum right now, beating somewhere between 60 and 80 times per minute without you asking it to, without you even noticing. Most people don't think about it until it gives them a reason to. And that's exactly the problem. Because the heart is not like a knee that aches when something's wrong, or a back that tells you when you've overdone it. The heart compensates. It adapts. It quietly reroutes. It works around damage for years, sometimes decades, without sending you a single signal. And then one Tuesday morning, while you're pouring coffee, it stops. That's not dramatic language. That's statistics. For 50% of men, the very first symptom of heart disease is sudden death. Not chest pain, not shortness of breath. Death. First symptom. I want you to let that land for a second. You've been going to your annual checkups. Your doctor runs blood work, looks at your cholesterol numbers, nods, says you look good for your age, and you walk out feeling reassured. But here's what that blood test didn't tell you: whether the cholesterol in your blood is already sticking to your artery walls right now. Standard lab panels measure what's floating in your bloodstream. They don't measure what's building up inside the pipe. That distinction is the difference between a warning and a funeral. To understand why this matters so much, you have to understand what's actually happening inside your coronary arteries, the vessels that wrap around your heart like roots around a tree trunk. Early anatomists thought they looked like a crown. That's where the word coronary comes from. But I want you to think of them differently. Think of them as the life support system for the most important muscle in your body. If one of those roots gets cut off, the branch it feeds dies almost immediately. There are two main arteries doing this work: the right coronary artery and the left coronary artery. The left one branches into a massive vessel called the left anterior descending artery, the LAD. In emergency rooms, this vessel has a nickname that says everything you need to know about it: the Widowmaker. The LAD supplies blood to the front and bottom of the left ventricle, the heart's primary pumping chamber, the one that pushes blood to your entire body. Think of it like the trunk of a tree. Block a small twig, you lose a leaf. Block the trunk, the whole tree falls. Now here's where it gets counterintuitive. Most people imagine arterial blockage the way they imagine a clogged drain. The pipe gets narrower and narrower, water slows down, you feel it happening, and eventually it stops. Logical, intuitive, and completely wrong. What actually happens is something called positive remodeling. As plaque accumulates on the inner wall of the artery, the vessel doesn't just narrow inward, it expands outward. The artery wall literally stretches to accommodate the buildup, keeping the opening for blood flow fully intact. You can have a massive amount of plaque inside your artery while the actual channel carrying your blood remains 100% open. Normal blood flow, zero symptoms, you feel great. This is the biological trap that kills otherwise healthy people. It starts with damage to the artery's inner lining, a surface that, in a healthy vessel, is smooth as Teflon. Blood cells glide past it without friction. But over decades, factors like chronic high blood pressure, elevated blood sugar, and even the cumulative mechanical stress of high-volume exercise act like sandpaper on that smooth lining. Microscopic scratches, tiny tears, Your body tries to fix them. It sends LDL cholesterol to the site like spackle to patch a wall. Then the immune system sends white blood cells to inspect the repair. Those cells absorb the cholesterol, become what we call foam cells, and eventually harden. Cholesterol, calcium, cellular debris, all fuse together into what we call plaque. The condition is atherosclerosis, and it doesn't hurt. It doesn't announce itself. It builds quietly for years, often beginning in your 30s, sometimes earlier, while you're at the gym, at dinner with your family, living what feels like a completely normal life. Here's where your blood type enters the equation, because not everyone's blood interacts with this process the same way. The biological variables you were born with, the antigens on the surface of your red blood cells, the clotting proteins in your plasma, the way your immune system handles inflammation. All of these things influence how aggressively plaque forms, how quickly clots develop, and how your body responds when something goes wrong. If you are type A, your blood is naturally thicker. It clots more easily. In ancient times, that was survival. Today, sitting in an office chair for 8 hours, it's a slow accumulation of risk. Type A individuals carry statistically higher rates of deep vein thrombosis, pulmonary embolism, and cardiac events. The same sticky quality that would have sealed a wound in the forest is quietly increasing your odds inside a modern sedentary life. If you are type O, your blood flows more freely, but that freedom cuts both ways. You bleed more easily, yes, but more relevantly, your gut lining carries a specific antigen called the H antigen, and certain bacteria, including Helicobacter pylori, the organism responsible for most stomach ulcers, have evolved to lock onto it like a key into a lock. Chronic gut inflammation, left unchecked, drives systemic inflammation. And systemic inflammation accelerates the very arterial damage we're talking about. The point isn't to frighten you. The point is that this is not random. This is biology. And biology can be understood, measured, and addressed. But first, you have to accept something that most people in their 40s resist. Feeling good is not the same as being healthy. Your heart can be failing you silently for a decade before it gives you a single warning. And the systems designed to catch it, annual checkups, basic blood panels, were not built for the kind of early, silent, soft plaque disease that kills healthy-seeming people. They were built to manage disease that's already visible, already advanced, already causing symptoms. You deserve better data than that. And that's exactly what we're going to talk about next. Let me introduce you to someone. His name is Robert. He's 50 years old. He runs 3 times a week. His cholesterol numbers are normal. His doctor told him 6 months ago that he's in great shape for his age. He watches what he eats, doesn't smoke, and sleeps 7 hours a night. By every conventional measure, Robert is doing everything right. One Saturday morning, during a local 10K race, something shifts. He doesn't feel crushing chest pain, nothing dramatic, nothing cinematic. He just feels off. His energy drops unexpectedly. A wave of nausea, a strange lightheadedness that he tells himself is probably dehydration. He slows down, finishes the race walking, sits by the water station and waits for it to pass. It doesn't pass. At the hospital, the doctors run a blood test and find elevated levels of a protein called troponin. Here's how I want you to think about troponin. Imagine a glow stick. As long as the plastic casing is intact, the luminescent liquid stays sealed inside. But if you snap it, if you bend it past its limit, the casing cracks and the liquid leaks out. Heart muscle cells are full of troponin. When those cells die, they break open, and the troponin spills into the bloodstream. Robert is having a heart attack. When the cardiologists look at his arteries, they don't find a pipe that's 100% blocked. They find a 50% blockage. The artery is still half open. Blood is still flowing. And yet, Robert's heart muscle is dying. How? This is what's called a type 2 myocardial infarction. And it's one of the most misunderstood events in cardiovascular medicine. It's not about a complete blockage. It's about supply and demand. Think of it this way. While Robert was sitting on his couch watching television, that 50% blockage was essentially irrelevant. The hose was crimped, but enough water was getting through to water the grass. His heart was calm, its oxygen demands were modest, and the partially blocked artery was handling the job just fine. No symptoms, no warning. But the moment Robert started running, the moment his heart rate climbed to 160, then 170 beats per minute, everything changed. At that intensity, his heart doesn't want a garden hose worth of blood. It wants a fire hose. And the crimped artery can only deliver what it can deliver. Demand explodes past supply. The heart muscle starts to suffocate. That suffocation is called ischemia. And Robert had an additional factor making everything worse. Atrial fibrillation. Your heart runs on an electrical grid. Each beat is coordinated. A precise sequence of signals that causes the chambers to squeeze in a specific order, efficiently pushing blood forward. In atrial fibrillation, the upper chambers stop beating in that organized way and start quivering chaotically. The rhythm becomes erratic. The timing falls apart. Blood doesn't move through the heart as efficiently. And when you combine that chaotic rhythm with a partially blocked artery and a heart rate of 170, you've created what cardiologists call a perfect storm. The heart is beating too fast to fill properly. The artery can't keep up with demand, and the muscle begins to die. Robert survived, but he had no idea this was coming. And in the days before that race, he had felt completely, genuinely fine. Now let's go back to the other scenario, the one that kills people who never made it to the hospital. Remember how we talked about plaque? The hardened buildup of cholesterol, calcium, and cellular debris that forms inside artery walls over decades? Here's the part that most people don't know. Not all plaque is the same. Some plaque is old and hardened, calcified, dense, structurally stable. This is the kind that conventional imaging can detect. It's like a scar, tough, calcified, not going anywhere soon. But then there's soft plaque, newer, inflamed, filled with lipids and immune cells and inflammatory material. This plaque hasn't hardened yet, and structurally, it's fragile. Think of soft plaque like a blister beneath the surface of the artery wall, a thin membrane of tissue stretched over a pocket of volatile material. Most of the time it just sits there, stable, silent. You don't feel it. You can't feel it. But under certain conditions, a sudden spike in blood pressure, an intense burst of physical exertion, even a severe emotional shock, that thin membrane can tear. This is a plaque rupture. And when it tears, the contents spill directly into the bloodstream. The body responds as it always does when it detects an open wound. It sends platelets to clot the blood. It's exactly the right response if you cut your hand. It's exactly the wrong response inside a coronary artery. In a matter of minutes, that clot grows so large it completely seals off the vessel. The artery that was 80% open a few hours ago is now 100% blocked. Not by the plaque, by the clot. The plaque was the trigger. The clot pulled the trigger. This is a type 1 myocardial infarction. And this is the event that kills people who were running marathons 2 weeks before. People whose last blood test was perfectly normal. People who, by every visible measure, appeared to be thriving. Here's the number that tends to silence a room. The majority of heart attacks occur in arteries with less than 50% blockage. Not 90%. Not 80%. Less than 50%. Because soft plaques, the unstable, inflamed, newer ones, are far more prone to rupturing than the large calcified ones. A big, hardened, stable plaque might sit quietly for 20 years. A small, inflamed, soft plaque can rupture on a Tuesday morning with no warning whatsoever. And this is where your blood type becomes more than just a letter on a form. Because your blood type influences directly how aggressively your blood clots when that rupture happens. Type A individuals have naturally higher levels of von Willebrand factor and factor VIII, two proteins that drive clot formation. When a plaque ruptures in a type A person, the clotting response is faster and more aggressive. The window between rupture and full occlusion is shorter. The margin for error is smaller. Type O individuals, on the other hand, have lower levels of these same clotting proteins. Their blood is slower to clot, which means that in the same rupture scenario, a type O person might have slightly more time before the artery closes completely. Not a lot of time, but biologically measurable time. AB individuals carry a compounded risk profile, both A and B antigens influencing clotting behavior, combined with a tendency toward higher factor VIII levels and, critically, a specific vulnerability in the microvasculature of the brain, the tiny capillaries that feed neurons. Poor microcirculation, sustained over decades, quietly starves brain tissue of oxygen. The cognitive decline that researchers have linked to AB blood type doesn't happen overnight. It happens the way most damage happens, slowly, silently, and well before anyone thinks to look. This isn't fatalism. None of this means your blood type condemns you. It means your blood type gives you a map, and maps are useful, but only if you actually look at them. The tragedy isn't biology. The tragedy is going through life without ever reading the map you were born with. Block 4. Your blood type is not your destiny, but it is your blueprint. There's a conversation that almost never happens in a doctor's office. You sit down. They check your blood pressure. They review your labs. They maybe ask about your sleep and your stress levels. And somewhere in that file, recorded since the day you were born, never discussed, never analyzed in context, is your blood type. It's just sitting there, ignored, like a chapter in a book that nobody reads because they assumed it wasn't important. But here's what the research is telling us with increasing clarity. Your blood type is not just a transfusion compatibility code. It is a biological signature, and it shapes, in ways that are now measurable and documented, how your immune system behaves, how your blood flows, how your arteries age, and how your brain holds up over time. A landmark study published in the journal Neurology followed more than 30 people over multiple years and found that blood type is a direct predictor of cognitive decline and stroke risk. That's not a fringe study, that's 30,000 people. And the findings from the American Heart Association confirmed what researchers had been suspecting for years, that non-O blood types carry a statistically significant higher risk of heart failure. So let's build the full picture, not to frighten you, but to give you the kind of clarity that most people never get until it's too late. Let's start with type O, the most common blood type on the planet, carried by nearly 40% of the population. If you are type O, you were probably told at some point that you have the original blood, the hunter-gatherer blood, the universal donor, and there's a quiet pride that comes with that. You feel like the baseline, the standard. But here's the irony that most type O people have never heard. Your blood, precisely because it lacks the A and B antigens, has lower levels of a clotting protein called von Willebrand factor. Think of this protein as biological glue, the substance that helps plug a wound when you're bleeding. Type O blood has less of it, which means your blood is slower to clot. On one side of that equation, you have protection. Type O individuals have a measurably lower risk of deep vein thrombosis and stroke, caused by random clot formation. Your blood flows freely. Your cardiovascular risk profile from a clotting standpoint is genuinely favorable. But the other side of that equation is where things get serious. In the event of major trauma, a serious car accident, a complicated surgery, an internal bleed, you are at significantly higher risk of hemorrhaging. Trauma surgeons will sometimes recognize a type O patient not from their chart but from the table. The bleeding is harder to control. It takes longer to stop. The margin is thinner. And then there's your gut. Type O blood cells express something called the H antigen, a molecular structure on the surface of your red blood cells that certain bacteria have spent millions of years evolving to recognize. Helicobacter pylori, the bacterium responsible for the majority of stomach ulcers, has a near-perfect molecular key that fits the H antigen lock. It doesn't just infect your stomach. It anchors itself to your gut lining with unusual efficiency. Cholera, norovirus. These pathogens also show a documented preference for type O hosts. This isn't weakness, it's specificity. Your biology simply laid out a welcome mat for certain guests. What this means practically: Chronic gut inflammation driven by H. pylori infection, often silent, often dismissed as ordinary digestive discomfort, creates systemic inflammatory pressure over time. And systemic inflammation, as we've established, accelerates arterial damage. The gut and the heart are more connected than most people realize. A stomach that's been quietly inflamed for a decade is contributing to arterial wear that shows up on a scan years later. Now let's talk about type A. And this is where the story shifts completely. If type O blood is water, type A blood is closer to syrup. Not dramatically, not visibly, but measurably at a biochemical level. Type A individuals carry higher concentrations of von Willebrand factor and factor VIII, the same clotting proteins that type O lacks. The blood coagulates more readily, more efficiently, more aggressively. In the ancient world, that was survival. A clean wound that sealed quickly was the difference between life and death on a hunt, in a fight, in childbirth. Type A clotting biology was built for a world where physical trauma was a daily possibility. But you are not living in that world. You are sitting in a chair, commuting in a car, spending 8 hours in front of a screen. And in that sedentary modern context, blood that loves to clot becomes a liability. Deep vein thrombosis, clots forming in the deep veins of your legs, is significantly more common in type A individuals. Pulmonary embolism, stroke from clot-driven occlusion. These aren't just theoretical elevations in risk. They're documented across multiple large-scale epidemiological studies. But there's another layer to the type A profile that goes beyond clotting. Type A individuals also tend to have biologically higher cortisol responses. Cortisol, the stress hormone, is not inherently dangerous. It's designed to mobilize your body in a crisis. But chronic cortisol elevation, the kind that comes from modern sustained psychological stress, has a direct effect on blood viscosity. Stress literally thickens your blood. And for a type A person whose blood is already on the thicker end of the spectrum, this creates a compounding effect. More stress, thicker blood, higher clot risk, elevated inflammation. And here's the piece that tends to hit people hardest. Epidemiological research has found a statistically meaningful association between type A blood and certain cancers, specifically gastric and pancreatic cancer. The proposed mechanism involves how the A antigen affects cellular adhesion and immune signaling. The same H. pylori bacterium that targets type O gut lining interacts differently with the A antigen, driving a more exaggerated inflammatory response that, over time, can create the conditions for cellular damage. This is not a death sentence for type A individuals, but it is a blueprint that demands a specific response. Movement is not optional for you. It is pharmacological. Every 45 minutes of sitting is a missed opportunity to move blood that wants to thicken. Anti-inflammatory nutrition isn't a trend for you. It's maintenance. Ginger, garlic, turmeric, omega-3 fatty acids. These are not superfoods. They are tools that work directly against the biological tendencies your blood type creates. And stress management, real stress management, not just the idea of it, is probably the single most underestimated intervention available to a type A adult over 40. Because you weren't born broken. You were born with a specific set of tools. Some of them work brilliantly in the right context. Some of them need to be consciously counterbalanced in the context you actually live in. That's not a burden. That's information, and information, used properly, is the most powerful health intervention there is. Let's talk about type B. Type B is found in roughly 10% of the population. Less common, less discussed, and in many ways the most underrepresented blood type in mainstream health conversations. If you are type B, you probably don't hear much about yourself in these discussions. Most of the research spotlights type A and type O. Type B sits quietly in the background. But quietly doesn't mean safely. Type B blood originated, according to genetic research, in the populations of the Himalayan highlands, a harsh, demanding environment that selected for a robust and reactive immune system. And that's exactly what type B carries, an immune system that responds aggressively, decisively, sometimes too too aggressively. That strength comes with a specific cost. Type B individuals tend to have chronically elevated levels of C-reactive protein, CRP, which is one of the primary markers for systemic inflammation in the body. Not the acute inflammation that comes from fighting a virus or healing a broken bone. Chronic, low-grade baseline inflammation. The kind that doesn't make you feel sick. The kind that just quietly burns in the background for years, wearing down the inner lining of your blood vessels the way friction wears down a surface over time. Think of your arteries as a garden hose. In a healthy vessel, the inner surface is smooth, pliable, and frictionless. In a type B individual with chronic vascular inflammation, that inner surface gradually becomes rougher, less pliable, more reactive. Over years, this manifests as peripheral artery disease, reduced blood flow to the extremities, hands that are always cold, feet that go numb, a heaviness in the legs that you've probably blamed on aging or poor sleep. It's not aging, it's inflammation, and it's addressable. There's also the infection profile to consider. The B antigen, the molecular structure on the surface of type B red blood cells, acts as a preferred attachment point for specific pathogens. Salmonella, E. coli. These bacteria use the B antigen as an anchor, locking into the gut lining with unusual efficiency. This means that when a type B individual encounters contaminated food, undercooked poultry, raw eggs, improperly handled meat, the resulting infection doesn't just cause a bad evening. It tends to be more severe, last longer, and drive a more pronounced inflammatory response. And every significant gut infection, in a person already predisposed to chronic vascular inflammation, is another deposit into the arterial damage account. Here's what this means practically for anyone with type B blood. Your early warning system lives in your extremities. Numbness in the hands or feet isn't just inconvenient. It's a signal that your peripheral vasculature is under pressure. Nitric oxide becomes your most important dietary ally. Beets, dark leafy greens, foods that naturally promote vasodilation, the widening of blood vessels, work directly against the inflammatory narrowing that type B biology tends to drive. Food hygiene isn't paranoia for you, it's prevention. Knowing how your body responds to foodborne pathogens, more severely, more durably, should change how you handle raw proteins in the kitchen and how quickly you take gut symptoms seriously when they appear. Now we come to AB. And this is where I want you to pay close attention, especially if you're over 40 and you carry this blood type. Because the research here is striking. AB positive is found in less than 4% of the population. You have both the A and B antigens on the surface of your red blood cells, which makes you the universal recipient for blood transfusions. In an emergency room, your options are wide open. Almost any blood type is compatible with yours. That sounds like an advantage, and in trauma, it is. But inside your body, day to day, year after year, the AB profile creates something that researchers have increasingly linked to a specific and sobering risk: accelerated cognitive decline. The study published in the journal Neurology, the same one that followed over 30 individuals, found that people with AB blood type were 82% more likely to develop memory problems and cognitive impairment than those with other blood types. 82%. That's not a marginal elevation. That's a fundamental shift in trajectory. The mechanism centers on something called endothelial function, the way your blood vessel walls regulate themselves. Because AB individuals carry both the A and B antigens, they tend to have elevated levels of clotting factor 8, even higher than type A alone. This creates what researchers describe as a sludge effect in the microvasculature, the tiny hairline capillaries that thread through brain tissue, the ones responsible for delivering oxygen to neurons and clearing metabolic waste, become gradually compromised. This isn't something you feel in your 40s. You might not feel it in your 50s, but it's happening, slowly, steadily. Neurons that are chronically under-oxygenated don't die dramatically. They just function less efficiently. Connections weaken, processing slows. What looks like normal aging at 65 may have been a preventable, decades-long process of microvascular compression that started at 45. Here's what makes this particularly important for anyone in this audience. You are not yet at the end of the timeline. You are in the middle of it, which means intervention still has leverage. Cardiovascular exercise, not for aesthetics, not for weight management, but specifically for cerebral blood flow, becomes non-negotiable for AB individuals. When you elevate your heart rate in a sustained way, you force blood into those tiny capillaries. You create hydraulic pressure that pushes into the microvasculature that chronic sludging tends to compromise. You are literally irrigating your brain. Blood pressure management for AB individuals is not just a cardiovascular issue. It is a cognitive preservation strategy. Because elevated blood pressure accelerates the exact kind of microvascular damage that the AB profile already predisposes you to. Every point of sustained hypertension above optimal is compounding a risk that's already elevated by biology. And here's the connection that ties everything back to the heart. The same microvascular dysfunction that erodes brain function over decades is operating in parallel inside the coronary circulation. AB individuals aren't just at elevated cognitive risk. They're carrying a circulatory profile that, without active management, ages faster than the exterior suggests. The body is a system, not a collection of separate organs that happen to share a body cavity. What happens in the brain's capillaries is a reflection of what's happening in the heart's capillaries. What's happening in the gut's inflammatory environment is feeding the arterial inflammation upstream. This is why blood type matters, not as a label, as a lens. A lens through which to understand the specific way your body ages, the specific vulnerabilities that compound over time, and, critically, the specific interventions that counter them most effectively. You were handed this blueprint at birth. Most people never read it. You're reading it now. Block 6. The negative zone. When rarity becomes risk. There's one more dimension to this conversation that most people have never considered. And it involves a protein so fundamental to your biology that its presence or absence determines not just how your blood behaves, but whether your own immune system might one day turn against someone you love. We've been talking about blood type in terms of A, B, and O, the antigens that sit on the surface of your red blood cells, like biological identification tags. But there's a second layer to your blood type that sits alongside those letters, almost always overlooked. The plus or minus sign at the end. Rh positive, Rh negative. That sign tells you whether your red blood cells carry a specific surface protein called the rhesus factor, the Rh factor. If you're positive, you have it. If you're negative, you don't. And that single missing protein creates a cascade of biological consequences that are profound, sometimes life-threatening, and almost never fully explained outside of a specialized medical context. About 15% of humans are Rh negative. That's a significant minority. And if you're in that group, what I'm about to tell you applies directly to you. Let's start with the most urgent scenario. If you are an Rh negative woman and you carry an Rh positive baby, which happens frequently, since Rh positive is the dominant genetic trait, your immune system may identify your own child as a foreign invader. Not metaphorically, literally. Your white blood cells can cross the placental barrier and begin attacking the fetus's red blood cells, destroying them from the inside. This condition is called hemolytic disease of the newborn. And historically, before modern medicine understood what was happening, it killed infants and devastated families with no apparent explanation. Today, there is a solution. A single injection called Rogam, given during pregnancy and after delivery, effectively cloaks the baby's Rh positive cells so your immune system doesn't detect them. It turns a potentially fatal immunological conflict into a non-event, but only if someone in that medical encounter knows to offer it, only if the conversation happens, only if you know to ask. This is why knowing your blood type, truly knowing it, having it documented, having it discussed, is not bureaucratic detail. It is clinical urgency. Now let's talk about O negative. Perhaps the most misunderstood blood type in existence. If you are O negative, you have probably been told you are the universal donor, the hero of the blood bank, the type that emergency rooms always need and never have enough of. And that's true. In a crisis, your blood can be given to anyone. No compatibility testing required. O negative is what paramedics reach for when there's no time to run a type-in screen and someone is bleeding out on a table. That sounds like power. And in one direction it is. But flip it around. Because you have 0 antigens, no A, no B, no Rh, you are compatible with almost no one. In a mass casualty event, when the blood bank is under pressure and supplies are allocated by compatibility, O negative bags are rationed first. Other blood types have options. You have one, another O negative donor. And O negative individuals make up less than 7% of the population worldwide. If you are O negative and you suffer major trauma, a serious accident, an emergency surgery, a hemorrhagic complication, the hospital needs to find that specific rare bag quickly. Small clinics and regional hospitals often don't stock enough of it. In a large-scale emergency, the supply can be exhausted within hours. This isn't hypothetical. This is documented in mass casualty event reports from hospitals around the world. And O-negative individuals still carry all the gut vulnerability we discussed earlier. The H antigen that makes them preferential targets for H. pylori, norovirus and cholera. Which means you combine a higher risk of severe infection-driven dehydration with a blood type that's hardest to replace if that dehydration escalates to organ failure requiring aggressive intervention. For O-negative individuals, practical preparation is not paranoia, it is rational self-preservation. Wearing a medical identification bracelet that clearly states your blood type saves critical minutes in an emergency. Minutes that in trauma medicine are measured in muscle tissue and brain cells. Knowing which hospitals in your region maintain large blood banks is not excessive. It is the same logic as knowing where the nearest trauma center is. Now let's look at A negative and B negative, because these profiles carry the clotting and inflammation risks of their positive counterparts, amplified by the scarcity problem. A negative individuals have the same sticky, hypercoagulable blood profile as A positive. The elevated clotting factors, the cortisol sensitivity, the statistically higher risk of thrombotic events. But when that elevated clotting risk leads to a cardiac event or a surgical emergency, the pool of compatible blood is dramatically smaller. A negative individuals can only receive a negative or O-negative blood. Both are among the rarer types. In a busy hospital on a difficult night, that compatibility constraint can become a life or death bottleneck. B negative carries the same dynamic. The vascular inflammation, the peripheral circulation risk, the infection susceptibility tied to the B antigen, and a blood type found in less than 2% of the global population. Fighting a two-front biological war while operating with the rarest supply lines. For both A negative and B negative individuals, there is a strategy that most people have never heard their doctor suggest: autologous donation. If you are approaching a planned surgery, even an elective one, you can donate your own blood in the weeks prior and have the hospital store it specifically for your procedure. You become your own blood bank. You eliminate the compatibility uncertainty entirely. It's available, it's documented, and it's almost never offered proactively. And then there is AB negative, less than 0. 6% of humans carry this blood type. If you are AB negative, you are, in the most literal biological sense, extraordinarily rare. You carry both A and B antigens, but no Rh factor. A combination that produces what researchers describe as erratic immune signaling. Sometimes underreactive to viral threats, sometimes disorganized in its inflammatory response. The immune system of an AB negative individual doesn't follow predictable patterns as cleanly as other types, and in a supply crisis, AB negative individuals face the most constrained options of anyone. Compatible donors are found in a fraction of the population. There's a principle here that goes beyond blood type. It's about knowing your specific biological profile with enough precision to make decisions that match your actual risk landscape, not a generic one, not the average person's risk profile, yours. The medical system, for all its sophistication, tends to manage populations. It builds protocols around what's most common. It addresses the median. But you are not the median. You are a specific person, with a specific blood type, a specific cardiovascular history, a specific inflammatory baseline, and a specific set of vulnerabilities that have been quietly accumulating since the day you were born. The question isn't whether you have risk. Everyone over 40 has risk. The question is whether you know what your risk actually looks like. Because the difference between a person who acts on that knowledge and a person who doesn't isn't usually intelligence. It isn't usually access. It's almost always the moment when someone finally made the invisible visible. That moment can be now. Before I go any further, I want to pause for just a second. Not to interrupt what we're building here, but because something genuinely matters to me. We're getting close to a milestone for this channel. A number that represents real people, people like you, who decided that understanding their biology was worth their time. And if you've made it this far into this video, you are exactly the kind of person this channel exists for. So, if you're not subscribed yet, I want to invite you to do that right now. Hit the subscribe button, turn on notifications, because every single week we go this deep. And every protocol, every recommendation, every mechanism we break down here is reviewed by a clinical pharmacist and researcher before it reaches you. This isn't content, this is due diligence. And honestly, if you're over 40 and you're watching a video like this, you already know that the people in your life who need this information probably aren't looking for it yet. That's usually how it works. The people who need it most are the ones who haven't started asking the questions. So subscribe and think about who in your life needs to hear what we're talking about today. Now, back to what might be the most important part of this entire conversation. Because everything we've discussed so far, the blood types, the clotting profiles, the inflammation, the soft plaque, all of it becomes actionable only when you have the right data in front of you. And here's the hard truth. Most people don't have the right data. Not because it's unavailable, but because nobody told them to ask for it. Let's start with what standard medicine actually measures, and what it quietly leaves out. When your doctor orders routine blood work, they are typically looking at a lipid panel, total cholesterol, LDL, HDL, triglycerides. These numbers have been the cornerstone of cardiovascular risk assessment for decades, and they are useful. They are not useless, but they have a fundamental limitation that is rarely explained to patients. A lipid panel tells you what's floating in your blood. It does not tell you what's sticking to your walls. Think about that distinction for a moment. You can have a perfectly normal LDL number and simultaneously have significant plaque burden inside your coronary arteries, because LDL cholesterol doesn't cause damage by simply existing in your bloodstream. It causes damage when it penetrates a compromised arterial wall and triggers the inflammatory cascade we discussed earlier. The quantity circulating in your blood and the quantity embedded in your arterial lining are two different measurements. Standard blood work only captures one of them. This is not a flaw in the system that nobody noticed. It's a design limitation that has been known for years. And yet, for most people over 40, a normal lipid panel is still treated as a green light, as evidence that the pipes are clean. They may not be. So what should you actually be measuring? The first tool that changes everything is the CAC score, coronary artery calcium scoring. It's a 5-minute low-radiation CT scan that measures the amount of calcified plaque in your coronary arteries. No contrast dye, no needles, no hospital stay. You lie still for 5 minutes and the machine produces a single number. A score of 0 means no detectable calcified plaque. And a score of 0 in a person over 50 is genuinely powerful information. It significantly reduces your 10-year cardiovascular risk estimate, sometimes enough to change medication decisions entirely. Research has shown that a 0 CRC score is one of the strongest negative predictors of near-term cardiac events available in clinical medicine today. A score above 100 tells you that plaque is present and meaningful. Above 400 places you in a high-risk category that warrants immediate clinical attention and aggressive risk factor management. Not someday, now. But here's the limitation of the CAC score that even many physicians don't communicate clearly. It only detects calcified plaque, the old, hardened, stable kind. The kind that's been there long enough to mineralize. It does not see soft plaque. And as we established in an earlier block, soft plaque, the newer, inflamed, lipid-filled kind, is actually more dangerous in the short term. It's the kind most likely to rupture. The kind responsible for heart attacks in people with relatively low calcium scores. The kind that killed the 48-year-old who had a normal stress test 8 months before. To see soft plaque, you need a CT angiogram, a more detailed scan that uses contrast dye to visualize both the calcified and non-calcified plaque within your coronary arteries. This is the most comprehensive, non-invasive window into what's actually happening inside your vessels. It doesn't just count the old damage, it maps the current, active, unstable threat. The CT angiogram is the difference between reading last year's weather report and looking out the window right now. Combined, these two scans give you a level of cardiovascular clarity that no blood panel can provide. You're not guessing anymore. You're not extrapolating from population statistics. You are looking at your specific arteries, your specific plaque burden, your specific risk profile, in real time. Now, layer your blood type onto that data. If you are type A and your CAC score is elevated, you know that your naturally hypercoagulable blood is operating in an environment of existing arterial damage, and that the combination demands immediate, specific intervention, not generic advice, specific protocol. If you are type O and your CT angiogram reveals soft plaque, you know that your lower clotting factor levels give you a slightly longer window between rupture and occlusion. But that window is measured in minutes, not hours, and the rupture risk is still real. If you are AB and your imaging shows early microvascular changes alongside even moderate plaque burden, you know that cognitive preservation and cardiovascular preservation are the same intervention, and that the time to act is not when symptoms appear, but right now, while the system still has full leverage. This is what personalized medicine actually means, not a genetic test that tells you vague predispositions in percentage points. A specific scan, interpreted through the lens of your specific biological profile, producing a specific action plan. And yet, most people, over 40, have never had a CAC score, have never been offered a CT angiogram outside of an emergency, have never had a physician sit down with them and say, "Here is what your blood type means for your cardiovascular risk, and here is the imaging we should be doing to verify what's actually happening inside you." That conversation should be standard. It is not standard, which is exactly why you're watching videos like this one. Block 8. The protocols that actually move the needle. Let me be direct with you for a moment. There's a particular kind of frustration that comes with being a thoughtful, informed adult over 40 who genuinely wants to take care of their health. You read the studies, you watch the videos, you adjust your diet, your sleep, your exercise routine. You do the things. And yet there's always this nagging sense that you're working from incomplete information. That the advice you're getting was designed for someone slightly different from you. Someone average, someone generic. You are not average, you are not generic. And the protocols that actually move the needle for your health are not the same for every person in this audience. They depend on your specific biology, your blood type, your inflammatory baseline, your clotting profile, your cardiovascular imaging results. So let's get specific, because specificity is the only thing that actually works. Let's start with the universal foundation, the interventions that apply across every blood type, every risk profile, every imaging result, the non-negotiables that the research consistently supports regardless of where you sit on the biological spectrum. Blood pressure control is first. Not because it's the most exciting topic, but because it is mechanistically upstream of almost everything we've discussed. Chronic hypertension is the sandpaper that creates microscopic tears in the arterial lining. It's the initiating insult that starts the entire plaque-forming cascade. Every point of sustained systolic pressure above 120 is adding friction to a surface that needs to stay smooth. And the damage accumulates silently over years, without a single symptom until the wall finally gives way. The target isn't 140. The research that shifted clinical thinking in the last decade, particularly the SPRINT trial, suggests that for adults at elevated cardiovascular risk, a systolic target closer to 120 produces meaningfully better outcomes, not dramatic outcomes on a single dramatic day, steady, compounding protection over years. What moves blood pressure practically? Sleep is probably the most underestimated lever. Chronic sleep deprivation, even the kind that feels manageable, the 6-hour nights that you've normalized because life is busy, elevates cortisol, drives sympathetic nervous system activation, and raises nocturnal blood pressure in ways that don't fully resolve during the day. One consistently good night of sleep doesn't fix this. Consistent sleep architecture, sustained over months, does. Sodium matters, but not in the way most people think. It's not about eliminating salt. It's about the ratio of sodium to potassium. Most adults over 40 in Western countries are consuming roughly twice the sodium and half the potassium their cardiovascular system needs. Leafy greens, avocados, legumes, and bananas aren't just healthy foods in a general sense. They are potassium delivery mechanisms that directly counteract the pressure-raising effects of sodium at the cellular level. Now let's get blood type specific. For type O individuals, the priority protocol centers on gut protection and controlled bleeding risk management. Your stomach acid is your first line of defense against the H antigen targeting pathogens that your biology preferentially attracts. This means being extremely judicious about proton pump inhibitors and antacids, medications that reduce stomach acid. In a type O individual, chronically suppressed stomach acid removes the primary barrier between the gut lining and H. pylori. If you are experiencing chronic reflux or digestive discomfort, the correct response is investigation, not suppression. Get tested for H. pylori specifically. Don't treat the symptom and ignore the cause. For surgical procedures, communicate your blood type proactively to every member of your medical team. Not just the anesthesiologist, the entire team. Type O individuals bleed harder and longer. This is not a complication. It is a known, manageable characteristic, but only if the team is prepared for it. Zone 2. Cardiovascular training is particularly valuable for type O. Sustained aerobic work at a moderate intensity, the kind where you can still hold a conversation but are genuinely working, drives collateral vessel formation over time. Your heart, like any muscle under consistent mild stress, begins building redundant pathways. Side streets around the main arterial highways. These collateral vessels are your biological insurance policy. They don't eliminate risk, but they buy time. And in cardiac events, time is the only currency that matters. For type A individuals, the protocol shifts significantly. Movement frequency matters more than movement intensity. The research on sedentary behavior and clotting risk in hypercoagulable individuals is clear. Extended periods of stillness allow the blood to pool and thicken in ways that increase thrombotic risk substantially. The intervention isn't a longer workout, it's interruption. Standing and moving for 2 to 3 minutes every 45 minutes of sitting produces measurable reductions in clotting marker activity. A longer gym session doesn't compensate for 8 hours of immobility. Aspirin therapy for type A, adults over 50 with elevated cardiovascular risk, is worth an explicit conversation with your physician. Not as a universal recommendation, but as a specifically relevant one given the clotting profile. Low-dose aspirin directly inhibits platelet aggregation. For a blood type predisposed to hypercoagulability, this pharmacological lever may carry more benefit to risk value than it does for the general population. The anti-inflammatory dietary approach for type A is not about restriction, it's about replacement. Replacing processed meats, which drive acute inflammatory responses and directly elevate clotting factor activity, with omega-3 rich proteins like wild salmon, sardines, and mackerel. Replacing refined carbohydrates that spike blood sugar and trigger endothelial inflammation with complex carbohydrates and fiber that stabilize glucose and feed the gut microbiome. The microbiome connection matters here. Emerging research suggests that gut bacterial diversity directly influences systemic inflammation levels. And for type A individuals already operating with elevated inflammatory and clotting tendencies, a compromised gut microbiome is compounding a risk that's already elevated. For type B individuals, the protocol centers on vascular protection and infection vigilance. Nitric oxide is your most important biochemical ally. It's the molecule that signals your blood vessels to dilate, to widen, relax, and allow blood to flow more freely. And type B individuals, with their tendency toward vascular inflammation and peripheral circulation compromise, need this signal consistently and reliably. The most direct dietary pathway to nitric oxide production runs through dietary nitrates, compounds found in beets, arugula, spinach, and dark leafy greens that the body converts to nitric oxide through a well-documented enzymatic pathway. This isn't a fringe supplement strategy. This is a clinically validated mechanism. Regular consumption of nitrate-rich vegetables produces measurable improvements in endothelial function within weeks. For someone whose peripheral circulation is already under inflammatory pressure, this is not a minor benefit. For AB individuals, the protocol is built around two parallel priorities: cerebral blood flow preservation and blood pressure optimization. These are not separate goals. They are the same goal approached from two directions. High-intensity interval training, HIIT, done 2 to 3 times per week, produces the strongest acute stimulus for cerebrovascular blood flow of any exercise modality studied. The rapid fluctuations in cardiac output during interval work force blood into the microcapillaries of the brain with a hydraulic pressure that steady-state exercise doesn't match. For an AB individual whose microvascular profile already predisposes them to cognitive decline, this specific training stimulus is not optional. It is targeted intervention. Chronic stress management for AB individuals carries more cardiovascular weight than most people realize, because the cortisol pathway in AB blood combines the clotting tendencies of the A antigen with the inflammatory tendencies of the B antigen. Sustained psychological stress in an AB individual is, biochemically speaking, a double activation event. Tools that genuinely suppress the cortisol response. Not tools that make you feel like you're managing stress, but tools that measurably reduce cortisol, include consistent sleep, regular moderate exercise, and evidence-based mindfulness practices. The research on cortisol reduction through mindfulness is robust. 8 weeks of consistent practice produces detectable changes in cortisol reactivity. That's not a long timeline for a measurable biochemical shift. And across all blood types, all risk profiles, all imaging results, there is one intervention that towers above the rest in terms of sheer impact per unit of effort. Quitting smoking, if you smoke. Full stop. Nothing we've discussed in this entire video, no dietary protocol, no exercise prescription, no imaging strategy, produces cardiovascular benefit that comes close to what smoking cessation delivers. The mechanical damage to the endothelial lining that smoking causes is direct, rapid, and cumulative. It is the single most efficient accelerant of every risk mechanism we've discussed. If this applies to you, this is where the conversation starts. And finally, the supplement conversation, handled honestly. Most supplements marketed for cardiovascular health are not moving the needle in any clinically meaningful way. But there are exceptions, and they're worth naming precisely because the research behind them is genuine. Magnesium glycinate. Deficiency is extraordinarily common in adults over 40, drives arterial stiffness and hypertension, and is correctable with modest supplementation. Omega-3 fatty acids at therapeutic doses, not the 1-gram capsules sold at grocery stores, but 2 to 4 grams of combined EPA and DHA daily, produce documented reductions in triglycerides and inflammatory markers. Coenzyme Q10 for individuals on statin therapy. Statins deplete CoQ10, and the resulting mitochondrial energy deficit in cardiac muscle cells is real and addressable. These are not magic. They are tools. Specific tools, with specific mechanisms applied to specific deficits. Which is exactly how the rest of this conversation has been framed. Not magic, not fear, not generic advice delivered to an imaginary average person. Real mechanisms, real data, real specificity. For you. There's a phrase used in emergency medicine that I keep coming back to. Time is muscle. It means that in a cardiac event, every minute of delayed intervention corresponds to measurable, irreversible loss of heart tissue. 20 minutes without blood flow and the damage begins. 90 minutes and the muscle turns to scar. Scar tissue doesn't contract. It doesn't pump. It just sits there. Permanent, silent evidence of a window that closed. But I want to apply that phrase differently today. Because the most important version of time is muscle isn't what happens in the emergency room. It's what happens in the years before anyone calls an ambulance. The decade of choices, measurements, adjustments, and awareness that either builds resilience into your cardiovascular system or quietly allows the damage to compound until the window closes. The emergency room is the last chapter. We've been talking about the chapters before it. And here's what I want you to understand about those earlier chapters. They are not written yet. Not for most of the people watching this. The biology we've discussed, the blood type tendencies, the clotting profiles, the inflammatory markers, the soft plaque that hasn't hardened, the microvascular compression that hasn't yet produced symptoms. All of it is still in motion, still responsive, still within reach of intervention. That is the most important sentence in this entire video. Let me tell you about two more people. The first is a 52-year-old man. Let's call him David. Type A blood, desk job. Manages his stress the way most men his age manage stress. By not managing it, by treating it as a fixed feature of life rather than a modifiable variable. His lipid panel has been normal for years. His doctor is satisfied. David feels fine. He runs on weekends, eats reasonably well, doesn't smoke. David has never had a khaki score, has never had a CT angiogram, has never had a conversation with anyone about what his blood type means for his clotting profile or his cortisol response. At 54, David has a heart attack. Not massive, he survives. The cardiologists find soft plaque in his LAD, the widowmaker, that ruptured during a particularly stressful week at work. The blockage was never above 60%. It never would have shown up as a significant finding on a standard stress test. His cholesterol numbers, even in the days before the event, were unremarkable. Nothing in his conventional medical record predicted what happened. But his biology did. His blood type did. His stress response did. His imaging, had anyone thought to order it, would have. The second person is a 54-year-old woman. Let's call her Christine. Also, type A, similar profile on paper. But Christine had a physician who ran a CAC score at 50. The score came back at 180, elevated, but not catastrophic. Enough to warrant a CT angiogram. The angiogram revealed soft plaque in two vessels, neither causing significant narrowing, both structurally unstable. Christine wasn't having symptoms. She felt fine. But now she had data. Real data. Specific data about her specific arteries. Her physician adjusted her medications. Christine changed her diet with genuine precision. Not general healthy eating, but targeted anti-inflammatory protocol designed for her clotting profile. She started interrupting her sedentary work hours with movement every 45 minutes. She addressed her sleep. She began a consistent stress management practice and stuck with it past the first 2 weeks. 4 years later, a follow-up CT angiogram shows stable plaque. No progression. No new soft lesions. No event. Christine didn't feel sick at 50. She didn't feel better at 54. She just never got worse. She preserved the baseline. She protected the window. David and Christine are not hypothetical constructs. They are composites of real patterns that play out in cardiovascular medicine every single day. The difference between their stories isn't luck. It isn't genetics alone. It's the moment when one of them got real information and acted on it. Now here's the part that I think deserves to be said plainly. The medical system is not designed to find Christine. It's designed to treat David. After the event, after the tissue is lost, after the scar is formed. The entire infrastructure of conventional cardiovascular care is built around managing disease that has already declared itself. Symptomatic disease. Crisis medicine. Brilliant, life-saving, absolutely necessary, and fundamentally reactive. The system will catch your heart attack. It will thread a catheter through your wrist, find the blockage, deploy the stent, and send you home with a prescription and a follow-up appointment. It will do this with extraordinary competence. What it will not do, at least not routinely, not proactively, is find the soft plaque before it ruptures. Map your specific vascular risk profile against your blood type. Tell you that your type A hypercoagulability combined with a stressful job and 8 hours of daily sitting is a combination that deserves specific targeted intervention starting now. That gap between what the system is designed to do and what you actually need. That gap is your responsibility to close. Not with anxiety, not with obsessive self-monitoring, with information measured clearly, interpreted thoughtfully, and acted upon consistently. Let me be specific about what that looks like in practice. If you are over 40 and you have never had a CAC score, Schedule 1. It is inexpensive, often available for under $100 out of pocket at imaging centers. Low radiation, non-invasive, and produces information that no blood test can replicate. In many cases, a 0 score provides genuine reassurance that changes the entire risk conversation. In other cases, an elevated score creates the urgency that motivates the deeper investigation that actually saves a life. If your CAC score is above 0, especially above 100, have a direct conversation with a cardiologist about a CT angiogram. Not a stress test, not just medication adjustment. A CT angiogram that specifically looks at soft plaque burden. That conversation may not happen spontaneously. You may need to initiate it. Do so. Know your blood type with certainty, not from memory, not from what you think you remember from a blood donation years ago. Confirmed, documented, communicated to your physicians as a relevant clinical variable, not just a transfusion code. If you are type A, your physician needs to factor your clotting profile into your cardiovascular risk assessment. If you are type O, your gut health is cardiovascular health, and that connection needs to be on someone's clinical radar. Get your inflammatory markers measured beyond the standard lipid panel. High sensitivity CRP, the same marker we discussed in relation to type B blood, is a direct reflection of arterial wall inflammation. It predicts cardiovascular events with power that standard cholesterol panels don't capture. Lipoprotein, LP, is a genetically determined lipid particle that dramatically elevates plaque formation risk and is almost never included in routine blood work despite being present in approximately 20% of the population. These are not exotic tests. They are available through standard laboratories. They require someone to order them. That someone starts with you asking for them. Measure your blood pressure at home, not once, consistently, because office blood pressure readings, taken in an environment of mild clinical stress, after driving to an appointment, in a room with a person in a white coat, are systematically higher than your real baseline. Home readings, taken consistently in the morning before coffee and in the evening before dinner, give your physician the data they actually need to make accurate decisions about your cardiovascular risk and your medication thresholds. And manage your blood sugar as though your heart depends on it, because it does. Elevated fasting glucose and insulin resistance are among the most potent accelerants of endothelial damage in existence. Chronically high blood sugar acts like concentrated sandpaper on the arterial lining, creating the very scratches and tears that initiate the plaque-forming cascade. Hemoglobin A1C, a 3-month average of blood sugar control, belongs in every cardiovascular risk conversation for every adult over 40. If yours is trending upward, even within the technically normal range, that trend is a signal. Act on it before it crosses a threshold that demands medication. None of this is complicated. None of it requires unusual access or extraordinary resources. It requires the decision to take your biology seriously enough to look at it clearly. And that decision, the one you make before any symptom appears, before any crisis declares itself, before anyone calls an ambulance, that decision is the whole game. The window is open. The question is what you do with it. Somewhere in your medical history, there is a file. It contains your birth date, your vaccinations, your allergies, the medications you've taken, the injuries you've had. It contains, somewhere near the top, a single letter and a plus or minus sign, your blood type, recorded once, referenced almost never, and never once explained to you in the context of how it shapes the way your body ages. Nobody sat you down at 40 and said, "Here is what this means for you specifically. Here is how your blood clots. Here is what your arteries are predisposed to. Here is what the research says about your cognitive trajectory if you don't address these specific variables in your specific biology. Here is your map." That conversation never happened. This video was that conversation. What we covered today isn't a collection of health tips. It's a framework for understanding your body as a specific individual system. One that was never average, never generic, and never fully captured by population statistics and routine blood panels. Your coronary arteries have been quietly adapting to decades of life, stretching outward to accommodate plaque that you can't feel, building collateral vessels around blockages that haven't yet declared themselves, running on compensated blood flow that looks completely normal until the second it doesn't. Your blood has been clotting or not clotting, according to the antigens you were born with. Antigens that influence not just what happens when you're bleeding on a surgical table, but what happens inside your arteries on an ordinary Tuesday morning when nothing feels wrong. And your body has been trying to tell you all of this, not with symptoms. Symptoms come late, if they come at all. With biology, with the mechanisms we've been tracing together for the past hour. The healthy heart attack is almost always a tragedy of ignorance, not stupidity, not negligence. Ignorance, the specific, preventable kind that comes from never having access to the right information at the right time. You have that information now. What you do with it is yours to decide. Not your doctor's decision, not your insurance company's decision. Yours. Because the window between where you are right now and where this biology leads unchecked, that window is still open. The plaque that hasn't ruptured, the clot that hasn't formed, the microvascular compression that hasn't yet reached the threshold of symptoms. All of it still in motion. All of it still responsive. That's not a small thing. That is everything. There's a moment in emergency medicine, the moment just before the moment, when someone is still savable, when the tissue is still alive, when the window hasn't closed. The entire discipline of preventive cardiology exists to make that moment irrelevant, to build so much resilience, so much redundancy, so much biological margin into a person's system that the crisis never arrives. You are in that moment right now, not in a hospital, not in crisis, in a chair or on a couch or on a commute, alive, asymptomatic, and now in possession of a map that most people never receive until after something has already gone wrong. Use it. If this video gave you something, a question you hadn't asked before, a number you're going to go check, a conversation you're going to have with your doctor, then do something with that momentum right now, before the tab closes and the day moves on. Subscribe to this channel. Every week we go this deep on topics that your physician doesn't have time to cover in a 15-minute appointment, reviewed by a clinical pharmacist and researcher before it reaches you. This is the work we do here. And then share this video with 5 people who need to hear it. Not 5 people who already obsess over their health. 5 people who feel fine, who haven't thought about this, who are living exactly the way most people live, trusting that no symptoms means no problem. Those are the people this conversation was built for. You know who they are. Leave a comment below. Not just a reaction, but something real. Tell me your blood type. Tell me what landed hardest. Tell me what question this raised that you're going to take to your doctor. And tell me what you want us to cover next. This channel exists because of those comments. The next video might come from yours. The information was always there. Now so are you.